So actually, it's going to be like a quite easy presentation, so you can all go back to sleep and to your digestion, because Oscar and Katerina already covered everything a few hours ago. So I'm just going to repeat the same stuff, but with a French accent. So close your eyes, imagine you're in Paris or in Provence. and so one of the questions is like, why does sagittal plane matters in the setting of a degenerative spondy? I mean, the answer is pretty obvious. It's because this is a sagittal problem. You know, it has been associated with maybe a higher pelvic incidence, but then when you just look at the X-ray, the main problem are loss of lumbar lordosis and sagittalisthesis. So this is like a purely sagittal problem. And if you take like an X-ray, instead of looking at just the lumbar spine, you look at like the full film of the patient, very often you're going to realize that those simple degen spondy, they actually fit most of the criteria of what we call adult spinal deformity. I mean, look at this patient. It doesn't look like terrible. But once you start to plug the number, it's like SVA of 13 centimeter, pelvic tilt of 30 degrees, a mismatch in lumbar lordosis versus pelvic incidence of 30 degrees. So this is a severe deformity according to the SRS criteria. It doesn't mean that you need to do T2 to pelvis fusion, of course. But this is a purely sagittal plane problem. So this is an example of a patient that came at one point to see Frank. So we don't really know what happened. You know that based on the chart, he had a laminectomy with a non-instrumented fusion. Then a few years after, like he was not doing that well, so one more level now with some screw, and then was still a terrible patient, so like a long fusion. And then this patient ended up with a sacral osteotomy. So, of course, this is not like the natural course of every single fusion, but you can see that a simple problem, if it's not managed like the proper way, that means that if you fuse a patient in the wrong position, and then the solution to the problem is to add one level and one more, you're going to end up with a very complex patient. And so what is the problem with a degen spondy? It's really unfortunate because it usually happens at L4, L5, once in a while like L5, S1, and that's where we're supposed to have most of the lordosis. So remember from yesterday, between 55 to 68% of the lordosis is from L4 to S1. And a degen spondy is a kyphotic pathology. So that's creating a sagittal malalignment. And so there is actually like a fair amount of literature on the topic. So, and in 2007, so Cédric Barré, which is a neurosurgeon from Lyon, already made a few statements. And one of the statements was like, you know, those patients tend to have a higher pelvic incidence than the average patient. And the other statement was that, well, they do compensate because usually, you know, they're not necessarily like the terribly old patients, so they still have some muscle. They compensate using the adjacent segment, so extending the adjacent segment or pelvic retroversion. So this conclusion was based on a study on 154 control and 40 patients with degen spondy. A few years after, Ferrero, so she's an orthopedic surgeon, she's almost done with her training, did a study that was based on the French Society of Spine Surgery. And so that's one of the first times that French people actually work with each other. So it's a multi-center study. It's very rare because remember, as a French, you don't like anybody. You don't even like the other French people. But they find a way to work together, and they had like more than 600 patients with also a control group. And it was only on lumbar degen spondy. And what they found is that overall, those patients had a larger pelvic incidence, but a smaller lumbar lordosis. So right away, you think about the mismatch. They also have a larger pelvic retroversion, so they compensate, and the trunk tilt forward. So they came up with a kind of an explanation. Maybe it's a vicious circle because you have a large pelvic incidence, therefore you're supposed to have a large lordosis. Maybe you're going to have like some facet loading because of the hyperextension. maybe because of the inclination of the sacrum, you're going to have some shear stress on the disc. So only bad stuff that happens on the spine. Combine this with the degenerative process and with the age, at one point something has to go. So either is a facet that open and start to slip, or is the disc that become a little bit like more flexible and start like to let like the spine goes. So back to the Ferraro study. So they did a first like classification, and they demonstrate that about 25% of the patient have a truncal inclination, so the trunk tilt forward, and 62% of the patient do not have a truncal inclination but have a pelvic retroversion. That means they compensate. So if you add those two numbers, that means that more than 80% of patients with degen spondy have some sign of malalignment in the sagittal plane. So more recently, and this was presented this morning by Oscar, Gilles did a work to classify those patients and try to come up with some guideline on what to do with those patients. They also validate their classification. Basically, the classification is based on the few parameters. So one of the parameters is the truncal inclination. The other one will be like the rotation of the pelvis, the compensation. And the third one will be like the focal deformity. So they define focal deformity as a disc smaller than 5 degrees. So if you look at the normative data, what do we know? We know that overall, and it's not really affected by the pelvic incidence, but overall from the L5, S1 disc is about like 13 degrees. The L4, L5 is about like 11 degrees. So they took like 50% of that being considered as a sign of focal deformity. And so the first type that they describe is a type that, you know what, at the end, it's not that bad because the SVA, the plumb line, is correct, no truncal inclination. The proportion between the lumbar lordosis and the pelvic incidence is also correct. So they call that an harmonious spine. So type 1A will be like, probably like the beginning of the spondy, like the very, very light degenerative spondy. And in this case, they say, you know what, if the surgery is indicated, probably decompression will be sufficient. Again, I say if the surgery is indicated. Type 1B, again, like the global alignment seems to be fine. There is no pelvic retroversion. The overall lordosis is fine, but it's only fine because at one point you have a kyphotic segment, and then just above you compensate. And so they're like, well, because you have a kyphotic segment, if you need to operate the patient, maybe use an interbody fusion. Type 2, that now we're starting like to see some loss of lumbar lordosis, so a mismatch between the lordosis and the pelvic incidence, but the global alignment is still okay. So you have like two different ways that means that the patient compensate. On one end, the patient can compensate, look at that, with the flattening of the thoracic spine. So you're losing lordosis, straighten the thoracic spine, so they cancel each other. And the other type, so what they call like the 2B, is those patients do not compensate with the thoracic spine. Maybe they're older, maybe they're kyphotic, but they have to find another way to compensate. That means that they will retrovert the pelvis. So what is interesting is that every single concept that we learn from complex adult deformity, they're still applicable from an analytical point of view. So you can use the same concept to analyze those patients. And finally, like the worst patient from an alignment point of view will be like the one with a global truncal inclination. And so the question is like, should you restore the alignment in degenerative spondy? So there was like a great presentation, actually 3 of them this morning about like, when do you need to decompress, when do you need to fuse, when do you need to realign? The principle is very simple. Not when you need to start, but basically, like if you decompress and create an instability, probably should fuse. And if you fuse a malaligned spine, you should probably realign. And so that's the engineer point of view, like keep it simple. And so what did we learn in the literature? I mean, I'm going to go over a few studies. First, we learned that, you know what, there is probably some specific morphotype in terms of alignment that are associated to dedicated disease, like disc herniation, spinal stenosis, degenerative spondy. So we used just to put them all together and say, like, oh, those are degenerative patients. No, there are different, they compensate in a different way, and several studies now start to demonstrate that. And so, again, there is increased evidence that if you choose to fuse someone, fuse them in the right position, you will increase the likelihood of a good success. So I already mentioned this study yesterday, but I think it's a very important study. They demonstrate that after 1 to 3 level fusion, if you fuse a patient with a mismatch between the lordosis and the pelvic incidence, then you have a 10 times higher risk of a patient requiring a revision surgery for adjacent segment disease. So if you do the fusion, just do it in a proper alignment. What do we learn from the literature? And there is probably maybe 20 to 30 papers that touch on the topic. So this is one of them. So that was in setting of overall degenerative pathology. Again, they demonstrate that if after the surgery there is a PILL greater than 10 degrees, then those patients will have a worse clinical outcome than the one that were aligned. Again, as we talked about yesterday, the alignment is not the key to every single surgery, but it's one of the components. Same in this study where they looked at the adjacent segment disease. So they demonstrate that those patients that were more likely to have some imaging sign of adjacent segment disease were the one with the worst segmental lordosis and the worst overall lordosis. Now, in terms of pelvic tilt, this study demonstrates that if after the surgery there is still some compensation, so remember, if there is a compensation, that means that there is a malalignment. People do not compensate to bother you as a surgeon. And the pelvic tilt, remember, if you retroverse the pelvis, this is going to impact your ability of having a normal gait. So, without any surprise, if after a surgery you have a high pelvic tilt, well, the clinical outcome is not as well as if you have a normal pelvic tilt. A very similar finding in this study that was dedicated on degen spondy. And finally, when you look at the more severe case, so this was, let me look at this. This was again on degen spondy. They demonstrate that, well, if after the surgery you have a SVA greater than 5 centimeters, you're going to have worse outcome in terms of SF36, ODI, or overall back pain. And so what is interesting that all those concepts, they're not new. So Dubousset described the importance of the sagittal plane in 1997. Okay, it was not in degenerative spondy, it was more in pediatric spondy, but they're very similar concept. And I think one of the problem is that we like to create category. So we're okay, these are the deformity people, these are the degenerative people, and we're going to have separate role. Sometimes it's the case, but at the end of the day, the same principle probably apply across the disease. So a good friend of mine, Justin Smith, who is a neurosurgeon, but is really not politically correct at all. So one day he was on the podium, and he's like, you know what? We are all deformity surgeons. Either you create the deformity or you correct the deformity. And so, that was obviously pushing a little bit, but I think what we learn every day and after Congress is you know what, whatever concept are relevant for the degen population, they're probably relevant for the deformity one, and vice versa. So I'm going to conclude on this topic. Thank you.